Hey, future nurses, NCLEX-bay is officially back in session, and we are kicking off this masterclass with the absolute most tested, high-yield topic that you simply cannot afford to miss for your upcoming exams: pediatric communicable diseases. Specifically, we're going to zero in on the HIV and AIDS clinical pathway. So grab your pens, get those highlighters ready, because we are going to master this exactly how it's going to show up on your test. We're breaking down everything from pathology all the way to at-home care. Let's dive in. Here's our quick blueprint for today. We're covering pathology and transmission, age-based diagnostics, safe immunization protocols, at-home caregiver instructions, and then wrapping up with a rapid-fire clinical knowledge check to see what's stuck. All right, part 1, pathology and transmission. Let's look at how this virus actually operates inside a child's body. So looking at the immune system's cellular defense hierarchy here, you'll see HIV doesn't just attack randomly. It specifically targets, infects, and destroys your CD4 plus T cells. And as that CD4 count gradually drops, it causes a progressive and really devastating immunodeficiency. The body is essentially losing its main commanders of the cellular defense system. Now, this brings us to a massive distinction you absolutely have to make on your exams. The virus, HIV, causes the progressive immune destruction, but AIDS, that's the syndrome diagnosed when that generalized immune dysfunction actually allows specific, severe, opportunistic illnesses to take hold. You really got to know the difference between just having the virus and progressing to the actual syndrome. Let's talk about transmission. As a pediatric nurse, you need to differentiate between vertical and horizontal. Vertical, or perinatal transmission, happens directly from an HIV-infected pregnant woman to her fetus. Horizontal, on the other hand, is through intimate contact with infected blood or body fluids. For us in pediatrics, vertical transmission is the huge focus for our early interventions. Now highlight this number, circle it, draw a huge star next to it, 3 to 6 months. This specific age window is unbelievably dangerous for an infected infant. Why? Because the single most common opportunistic infection in kids with HIV is pneumocystis jirovecii pneumonia, and it almost always strikes infants right in this exact 3 to 6 month bracket. You have to monitor their respiratory status like a hawk. Moving right along to Section 2, age-based diagnostics. Diagnosing pediatric HIV has a really strict dividing line based on the calendar. And that crucial dividing line is the 18-month mark. If an infant is under 18 months old, you absolutely cannot use the standard ELISA or Western blot tests. The reason is that those tests detect antibodies, and maternal antibodies are transmitted right across the placenta. So if mom has HIV, the baby's going to have her antibodies, which triggers a false positive. Because of that, for any infant under 18 months, we rely entirely on tests that detect the actual virus itself, like the PCR or the P24 antigen assay. Once they cross that 18-month mark, their own immune profile takes over, and ELISA and Western blot become perfectly accurate. All right, Section 3, safe immunization protocols. Once we have a diagnosis, our nursing interventions have to be incredibly precise. Guys, this is a massive NCLEX alert. If a child has symptomatic HIV infection or severe immunosuppression, you must completely avoid live virus vaccines. No live measles, no varicella, no rotavirus. It's just way too dangerous. But you can, and absolutely should, administer inactivated vaccines. So they still need their yearly intramuscular inactivated flu shot and the inactivated polio vaccine. Just remember the golden rule. Inactivated means safe, live means dangerous. Next up, Section 4, at-home caregiver instructions. Beyond the clinic, caregivers shoulder a huge responsibility here. And honestly, these instructions are non-negotiable. Nutritionally, you're enforcing a high-calorie, high-protein diet to fight off wasting. But if you're immunosuppressed, they have to follow a strict neutropenic diet. That means 0 fresh fruits, no raw veggies, and no raw meat. Also, no sharing utensils. Everything goes through a dishwasher to fully sanitize it. Caregivers have to wear gloves when handling diapers and obviously restrict the child's contact with anyone who's sick. Every single step here is about preventing a life-threatening infection. So what happens if there's a blood or body fluid spill at home? You have to teach the caregiver this exact ratio, 10 to 1. That's 10 parts water to 1 part bleach. This is the clinically approved way to safely and effectively neutralize the hazard. Definitely lock that 10 to 1 ratio into your memory for exam day. All right, Section 5, clinical knowledge check. It is time to see if your brain is really back in the game. I've got 4 NCLEX-style questions based exactly on this blueprint. I'm going to read the question and the options, then you have exactly 5 seconds before the reveal. Let's go. Question 1. When assessing an HIV-infected infant for the most common opportunistic infection, which sign is the nurse looking for? 1. Cough. 2. Liver failure. 3. Watery stool. 4. Nuchal rigidity. Insert 5-second countdown timer and ticking sound here. And the answer is 1. Cough. Think back to that crucial 3 to 6 month window we just talked about. The major threat is pneumocystis jirovecii pneumonia. Watery stool and liver failure are systemic issues, and nuchal rigidity points to meningitis. But a simple, persistent cough, that is your major red flag for this massive respiratory threat. Let's hit question 2. Let's see if you caught the high contrast rules here. Which instruction regarding immunizations should be provided to the parent of an HIV-infected child? 1. No hepatitis B vaccine. 2. Inactivated influenza vaccine given yearly. 3. Varicella vaccine given before 6 months. 4. Western blot needed before immunizations. Insert 5-second countdown timer and ticking sound here. Excellent work if you picked 2. The inactivated influenza vaccine will be given yearly. Remember the rule. Only inactivated vaccines are safe for severely immunosuppressed kids. Live vaccines, like varicella and option 3, are completely contraindicated and super dangerous for these patients. Question 3, checking your diagnostic timeline. Which laboratory study is prescribed for an infant, specifically under 18 months, born to an HIV-positive woman? 1. Chest X-ray. 2. Western blot. 3. CD4 plus cell count. 4. P24 antigen assay. You absolutely nailed it if you picked 4, the P24 antigen assay. Remember, under 18 months, that baby is still carrying around maternal antibodies, so a Western blot would just give a false positive. You need the P24 antigen or PCR test because they look for the actual virus itself. All right, final challenge, spot the dangerous error. Which caregiver statement indicates a need for further teaching? 1. I will wash my hands frequently. 2. I will keep immunizations up to date. 3. I will avoid direct body fluid contact. 4. I can send my child to daycare with a low-grade fever. The answer is 4. If they think they can send a sick child to daycare with a fever, they desperately need further teaching. The biggest takeaway here is that a compromised immune system means you never send that child into a highly contagious environment like a daycare, especially when they are already showing signs of illness. Options 1, 2, and 3 are all perfect at-home care steps. So, how did you do after our break? Tell me your exact score in the comments. Share this explainer with your study group and save it for your final review. Before you step onto the unit, ask yourself, if an HIV-positive infant came into your ER right now, would you know exactly what diet to order and what vaccines to hold? Keep studying hard, and I will see you in the next masterclass.